Bismillah ar-Rahman ar-Rahim. Good evening, everyone. It's a true great honor to be with you this evening and share this eighth chapter of MENASO Academy, which is a unique platform. Occurs as a collaboration between the American Heart Association and MENASO, sponsored by Boehringer Ingelheim and Medtronic. This platform is a unique educational opportunity, hosting world experts in areas about stroke prevention, diagnosis, and treatment. My name is Adel Hazzani. I'm a stroke neurologist and professor of neurology at King Faisal Specialist Hospital in Riyadh, and I'm the vice president of MENASO. I would like to introduce the chairman of this session, Professor Hani Arif, who's known to most of the neurologists in the region. He is a professor of and head of neurology at Ain Shams University. He's a well-published and well-recognized figure in the region, and also collaborating with the authorities like World Stroke Organization, American Heart Association, well-published and been invited to many of the conferences and national meetings and international. We have three outstanding speaker tonight. I'm going to introduce the first two speakers. Before doing that, I would like to recommend for everyone to type their questions if they have questions at the Q&A box. We'll have a session for discussions at the end of all talks. And hopefully those talks will be made available later on online. So our first session is going to be focused about the hyperacute blood pressure management on both ischemic and hemorrhagic stroke, which is going to be presented by Dr. Adam D. Havenon, who is an associate professor of neurology at Yale. He obtained his medical degree from Brown School of Medicine, followed by a neurology residency at University of Utah. He did his vascular neurology fellowship at University of Washington, and he was a faculty member at University of Utah between 2014 and 2021. Then he moved back to Yale. His interest in clinical practice includes evaluation and treating acute stroke patients in the emergency and in patients, together with outpatient stroke prevention. He's an author, published more than 100 peer-reviewed articles in high-impact journal, and he's member of the American Heart Association, American Stroke Association, and the American Academy of Neurology. Following the talk of Dr. Havenon, we will have Dr. Eva Mistry, who is an assistant professor of neurology at the Department of Neurology and Rehabilitation Medicine in the University of Cincinnati. She worked as an assistant professor prior to that at the Vanderbilt University in Nashville. She completed her medical degree from NHI Municipal Medical College in India, got a Master of Science in Clinical Investigations from Vanderbilt in Nashville. She published many peer-reviewed articles and research focused on stroke and rehabilitation. Without further ado, the floor is yours, Dr. Adam.
Thank you so much for the opportunity to give a short talk today about blood pressure management after spontaneous intracerebral hemorrhage. My name is Adam de Havenon. I'm an associate professor of vascular neurology at Yale School of Medicine in Connecticut in the United States. I have Some disclosures, conflict of interest. I do receive royalties from the website Up to Date for an article about antihypertensive therapy for secondary stroke prevention. And then other funding unrelated. As background, I would say that blood pressure management in ICH, and we're talking here about spontaneous ICH, not traumatic, I would say that it's controversial. We know from really going on now 20 years of research that the majority, up to 70 or 80% of patients with ICH present with an acute hypertensive response. And that may well be the cause of their intracranial hemorrhage, or it may be a secondary consequence. And we also know that there is a U-shaped association, sometimes more J-shaped, but predominantly U-shaped, with the probability of a worse outcome after ICH, meaning that individuals with low blood pressure at presentation or very high blood pressure appear to have worse outcome. However, as I'll show you in the coming slides, the studies that have acutely lowered blood pressure haven't been as successful as we hoped. The two main studies that form the body of evidence in this field are INTERACT-2, which Craig Anderson conducted and enrolled patients between 2008 and 2012. It was a multinational trial and recruited heavily in China. 68% of the 2,794 participants were from China. The inclusion criteria were a systolic blood pressure between 150 and 220 on presentation, a GCS of 4 or more, onset in the last 6 hours, and overall, the size of the intracranial hemorrhages was relatively modest at 11 milliliters at the median. The second trial that I'll talk about in depth is ATTACH or ATTACK, but depending on how you want to pronounce it, too, which was led by Adnan Qureshi. This also was an international multi-center trial, a little bit later than INTERACT. It enrolled between 2011 and 2015. And like INTERACT, it was well represented with Asian participants in ATTACH, 56%. But it also had a good representation of non-Hispanic Black individuals, primarily from the United States, as well as Hispanic individuals. The entry criteria were similar, but slightly different. Systolic blood pressure over 180, an ICH volume under 60 mLs. So they set a limit on that. The result, though, was very similar to INTERACT, with a median of 10 mLs compared to INTERACT's 11. GCS had to be 5 or greater, and the time window was a little more strict. It had to have an onset less than 4.5 hours. The intervention in INTERACT-2 was randomizing to what they called guideline blood pressure control, keeping the systolic less than 180, versus aggressive control, keeping the systolic less than 140. To do that, a number of different agents were used. The protocol at each individual site was determined in collaboration with the study investigators and reflected the drugs that were available and practice patterns. So there's a lot of heterogeneity here, but what you'll see immediately is that intravenous antihypertensives are far more common in the intensive arm. 90% of individuals got them versus only 42.9 in the guideline less than 180 arm. Otherwise, in terms of agents, just slightly lower here, you see all sorts of other agents were used. The primary outcome was an MRS of 3 to 5 at day 90. This was called major disability. And secondary outcomes were the ordinal MRS, so each of the individual scores, and then EQ5D, which is a quality of life assessment, typically used as a cumulative across all 5 categories score. But in INTERACT, they a priori said that they would look at each domain within that. I want to highlight here that they did not find a statistically significant difference in their primary outcome. It was close, so the intensive arm had a rate of death or major disability of 52%. And excuse me, on the prior slide, it should have been MRS 3 to 6, not 3 to 5. Versus in the guideline arm, 55.6%. This translates into an odds ratio of 0.87. So effectively, if they had had another 1,000 or so patients, they would have had statistical significance. Nonetheless, the effect size is not huge. You would be looking at, treating close to 100 patients, perhaps, to have a meaningful impact. The ordinal Rankin was significant, and you can see the shifts here are primarily happening at an MRS of 1, which is higher in the intensive arm, and then some scattered differences beyond. But it really, although significant, reflects the increased statistical power of looking at an ordinal outcome rather than a fundamentally different outcome from this study. The EQ5D domains did show statistical significance, and I won't go into this much, except to say that these differences are relatively small. You'll see the hazard ratios there are kind of around the 0.8 or above range. So again, a direction of effect of benefit, but not something that was particularly strong or consistent. In the forest plot, looking at subgroups, we don't see much in the way of interaction, except for in the subgroup of patients without hypertension. There appeared to be a more significant impact of intensive blood pressure lowering. That, of course, may have to do with their cerebral perfusion at baseline, the range of pressures across which it was accustomed to perfuse the brain were obviously lower than those with hypertension. This may have led to increased benefit to tamping down the acute hypertensive response. But in any event, this is a subgroup analysis, and I don't think that too much weight can be placed on it. Moving on to ATTACH, the intervention was very similar. They had a range of blood pressures in the arms. In the sort of guideline arm, 140 to 179 systolic was the goal. In the intensive arm, 110 to 139. A major difference with INTERACT is that IV nicardipine was used as first line across the board. So this drug could be ready, it could be stocked, and I'll show you some interesting data about the time to achieving goal blood pressure that probably is a result of the approach that ATTACH has taken here. Second line was primarily labetalol. In some countries that didn't have intravenous labetalol, diltiazem or arapidil could be used. Shown here, you can see the two arms, the standard and intensive arm, separating very early, within an hour, and really getting down low and staying low across that first day, but also staying well controlled throughout the first several days as well. The outcome here is a little bit higher. So instead of an MRS of 3 to 6, it's 4 to 6. And secondary outcomes similar to INTERACT, or the EQ5D, and then an imaging outcome, which was collected in the majority of patients, looking at the expansion of ICH over 24 hours. Here's the shift plot of the modified Rankin. You can draw a line there between 3 and 4, and it's almost identical between the treatment arms. That resulted in a really null result. The relative risk here is 1.04. The p-value is not even close to significant. So the primary outcome in ATTACH, not even a direction of effect towards benefit. There was a direction towards benefit in the hematoma expansion outcome. And a number of post-hoc and secondary analyses have been done looking at this. And I think that it's probably true. I won't go into this data in depth, but keeping blood pressure lower results in slightly less growth of the hematoma. What that translates to clinically, I still don't know, because nobody has definitively shown that that benefits outcome when achieved through pharmacotherapy. The forest plot is across the board not very exciting. The differences between these two trials are that ATTACH enrolled patients earlier after their onset, and it enrolled patients with overall lower systolic blood pressure. INTERACT had a less aggressive protocol. Their treatment failure, not meeting goals, was over 66% at an hour. In ATTACH, at 2 hours, it was only 12.2%. So we were really seeing good control of blood pressure in ATTACH. Here's an article that Dr. Toyota wrote recently that extrapolated that. And you can appreciate here that in ATTACH, they really get down to the goal quickly. INTERACT took quite a bit longer. It's sort of around the 6-hour mark here that they're down to goal, around 2 to 3 hours in ATTACH. And when I think about these differences, what I take away from it is that this is really a strength. There was a lot of different approaches to lowering blood pressure, intensities, time frames, and this heterogeneous data tells us that if there's an effect here, I don't know which subgroup it's in. I'm not sure that it gave us a roadmap forward for more trials, but it has led to American Heart Association recommendations that are across the board, level 2, lower level of evidence. And you'll see that in the most recent guidelines that just came out, they actually lead with the first recommendation being that you try to keep blood pressure smooth. So as opposed to prior guidelines that talked about goals and maybe there being data forthcoming to support them, now they're talking about reducing variability in blood pressure, which, if any of you know my research, is really my wheelhouse. That came from meta-analysis. It was a patient-level meta-analysis of both ATTACH and INTERACT that was in Lancet. And it looked at the mean blood pressure and saw an effect when you combined both trials. very modest, but a more significant effect for variability on both good outcome and other binary cut points for the MRS. I also published analysis in stroke that looked at this just in ATTACH. And we saw in the first 24 hours, which is panel A here, model 1, 2, and 3 are different adjustments, but a consistent relationship between increasing quintiles of variability and worse outcome on the mean utility weighted modified Rankin score. We also saw in the subacute period here, going out several days, an even stronger association between variability and worse outcome. The second AHA recommendation is that initiating treatment within 2 hours of onset and reaching target within an hour can be beneficial to reduce the risk of hematoma expansion and improve functional outcome. This is post hoc analyses, so it gets a lower level of recommendation, but I think that's sound. I think that you should get blood pressure down from 200 to around 140, and you should do it fairly quickly. Additional guideline recommendations here are that the target should be about 140, and it's reasonable to keep the range of 130 to 150. However, because these trials didn't enroll patients with large or ICH that was causing mass effect and required surgical decompression, we don't really know what we should do with blood pressure for that population. They do now say that there is evidence of harm in reducing lower than a systolic of 130. That is based off adverse events associated with the intensive treatments in those trials. I'll just briefly touch on subacute goals to say that, after the first week, you just go for standard secondary stroke prevention. So you try to get patients under 130 over 80. First line, I recommend calcium channel blockers. They reduce variability. ACE inhibitors and thiazides. Beta blockers, I think, are more controversial, and I really save them for patients with specific indications. So heart failure with reduced ejection fraction, AFib for rate control, things like that. I do think, though, if patients have other comorbidities, like if they have stage 1 chronic kidney disease, if they have known vascular cognitive impairment, and others, you can shoot for a systolic of less than 120. That is guideline recommended in these subgroups. So I have a kind of tailored secondary stroke prevention goal for long-term blood pressure control. Thank you very much. I'm going to pass off, but it's been a pleasure giving this presentation.
Great, thanks. Hello, everybody. It's my pleasure to present hypertension control in the acute ischemic stroke now following Dr. de Havenon's great talk about hypertension for ICH patients. I'm Eva Mistry. I'm an assistant professor of Department of Neurology and Rehabilitation Medicine at University of Cincinnati in Ohio in the United States. And these are my disclosures. The most relevant ones are that I do receive a grant from NIH for conducting a BEST-2 trial that looks at blood pressure in endovascular thrombectomy treated patients, which I will talk about. And I also receive compensation from the American Heart Association for editorial activities, and AHA is in partnership with Middle East North American Stroke Association sponsoring this program today. Jumping right into the presentation, just a brief background about hypertension and acute ischemic stroke and what we will be talking about in this presentation today. Hypertension is a prevalent occurrence in patients who present with an acute ischemic stroke. In fact, more than 70% of these patients have a presentation blood pressure of more than 140 over 90, meeting the criteria for a hypertension or hypertensive response at the start of their stroke. This is likely a reactive phenomenon, although we do know that hypertension at baseline is a known risk factor for incidence of an ischemic stroke to begin with. Some of this hypertension at the presentation of acute ischemic stroke is felt to be reactive, sort of in response to the occurrence of ischemic stroke itself. If hypertension at presentation in acute ischemic stroke is a modifiable risk factor, especially in terms of improving patient outcomes, is yet unknown. So we will talk about and think about hypertension control for this patient population in terms of the type of acute stroke reperfusion treatment that the patients are planned for or administered, and which stage of that treatment the patients are at, versus if no treatment is administered or planned for at all. So I would encourage you to think about the goals of blood pressure in terms of the treatments planned, at least in the acute stage of ischemic stroke. So let's just delve a little bit upon what I mean by reactive or permissive hypertension in relation to brain ischemia. As you already know, when there is a vessel occlusion in the brain, there is an immediate after effect on the brain tissue that's supplied directly by the vessel territory that is occluded. And that sort of turns almost in the matter of minutes into irreversibly damaged brain tissue. In most cases, we refer to this as an infarct core. But there is a larger area that is not immediately turned into irreversibly damaged tissue, but is sustained by collateral blood flow or blood vessels that take over the function of the primarily occluded blood vessel. And this sustained brain tissue is called the penumbra. The crux of acute ischemic stroke treatment is to get the clot out so that before the collateral blood flow fails and ischemic core increases to now involve the previously not irreversibly damaged tissue, i.e. penumbra, is not changed into ischemic core to begin with. And partially also is to maintain the collateral blood flow such that we can give time for these acute ischemic stroke reperfusion treatments to be administered and for them to work. So that is the reason why we allow for higher than normal blood pressure goals in the setting of acute ischemic stroke, also we call permissive hypertension. The goal is so that with the increased blood pressure, the collateral blood flow in the brain is sustained to sustain the ischemic penumbra. And that is a reactive phenomenon. Brain does that on its own due to autoregulation properties. And that is also why we use the principle of permissive hypertension in this setting. With that background, the current American Heart, American Stroke Association guidelines recommend exactly that. And the verbatim guidelines state that the patients who have a blood pressure less than 220 over 120 millimeters of mercury and are not planned for any kind of acute ischemic stroke intervention in form of intravenous or endovascular interventions, and do not have other comorbid conditions that require urgent treatment with antihypertensive agents, for example, heart conditions, etc., then initiating or reinstating the hypertensive treatment within the first 48 to 72 hours after acute ischemic stroke is not effective to prevent death or dependency. And in fact, this is recommended as a class 3 or a harmful evidence with a level of evidence A. In other words, unless the patient's blood pressure is above 220 over 180 in the setting that they are not receiving any intravenous or endovascular intervention for acute stroke, then the blood pressure is best left alone unless they have a comorbid condition requiring antihypertensive treatment. On the other hand, if the presenting blood pressure is above this threshold, again, this is only talking about patients who are not receiving intervention for their acute ischemic stroke, it is reasonable to drop the blood pressure by 15%. It's a very slow drop of their blood pressure in the first 24 hours. And again, these goals of permissive hypertension, these are way above a normal range of blood pressure, is such that the sustenance of collateral blood flow in order to maintain that penumbral tissue is allowed within this acute period. On the other hand, if the patients are in fact treated with endovascular thrombolysis, then this goal is slightly lower, such that before the initiation of intravenous thrombolysis, the blood pressure goals are recommended to be less than 185 over 110 millimeters of mercury with a class 2A, level of B, non-randomized study evidence. And once the intravenous thrombolysis is initiated and completed, this blood pressure is to be maintained at less than 180 over 105 for the first 24 hours. Again, lower goals than for those who are not treated with thrombolysis or thrombectomy, but still much higher or permissive blood pressure goal than what would we have for a normal patient, for example. It is important to note that this goal applies for patients who are treated for IV thrombolysis using extended window, within the extended window, for example, wake-up strokes, etc. They're subject to similar blood pressure goals. It is also important to note that these values are recommended because they are associated with lower incidence of hemorrhagic complications in setting of intravenous thrombolysis. And we have known this from early days of NINDS TPA trials in 1990s. Not that because these blood pressure goals are associated, or lower blood pressure goals than these are associated with improved patient outcomes per se. These are only associated with lower incidence of symptomatic ICH. In fact, there have been multitude of studies using many different kinds of antihypertensive agents within different windows, using different blood pressure goals that are below 180 millimeters of mercury that were recommended by using the NINDS TPA data initially. All of them, not to inundate you with these trial information, there are just many of them, but just to note that none of them have actually shown improvement in patient outcomes using antihypertensive agents in the setting of acute ischemic stroke. In fact, some of them may also have shown that lowering blood pressure using some of these agents may even be harmful to patients. It is important to note that these goals are coming because higher than 180 is associated with hemorrhagic complication, not because that lower blood pressure goals are associated with improved outcomes. There are some recommendations specifically in the American Stroke Association guidelines that touch on recommended agents. Continuing Dr. de Havenon's theme about blood pressure variability, the two agents that I wanted to draw attention even for acute ischemic stroke is nicardipine and clevidipine. As I mentioned, these are intravenous medications given as drip medications, or and they're not push medications, and they are associated with lower blood pressure variability. His work and other colleagues' works have shown also that blood pressure variability is extremely important in acute ischemic stroke, such that high blood pressure variability is associated with worse functional outcomes, as well as in some cases hemorrhagic outcomes. These two calcium channel blockers are known to reduce blood pressure variability, especially when compared to other classes such as beta blockers or other push medications. And so current practice, at least at our institution, is to use these medicines first before IV push is kicked in for blood pressure management in acute ischemic stroke patients who are hypertensive beyond these recommended goals. Switching gears a little bit to blood pressure management in the setting of endovascular treatment, and this is sort of a new and coming area of research. And one might wonder, why do we need to study blood pressure in the setting of thrombectomy, especially if we have had these many trials that have been neutral or negative in improving patient outcomes using antihypertensives in global ischemic stroke population? The reason is because most of these trials were done prior to the thrombectomy era. We know that IV thrombolysis is associated with successful recanalization in only 30 to 40% of the cases. And when the arterial clot is more proximal, such as ICA or M1, this rate is only 15 to 20%. As against that, endovascular treatment is associated with successful recanalization of larger clots in 70 to 80% of patients. Now, when this occurs so frequently, the rationale for maintaining permissive hypertension, to maintain that penumbra, it sort of doesn't make as much sense. Once the clot is out already, why would we want to sustain a penumbra when the primarily occluded blood vessel is recanalized and supposed to be perfusing that brain tissue to begin with? In some sense, you may even think that hyperperfusion related to permissive hypertension in this situation may be harmful to patients and may even cause hemorrhagic complications. At least observational studies have shown this, and I will tell you about those in just a minute. But at least in terms of the recent guidelines, there isn't a change in terms of the goal of blood pressure in acute ischemic stroke patients who are treated with thrombectomy when compared to IV thrombolysis, in that the blood pressure maintenance goal is similar. After thrombectomy, it has to be maintained less than 180/105 for about 24 to 48 hours. And similar goals have been endorsed by European Stroke Organization guidelines as well, again, without much supporting evidence or data behind this. Several observational studies, including ours, have shown that, in fact, high blood pressure after endovascular treatment is bad. We have found that a peak systolic blood pressure of around 160 millimeters of mercury post EVT dichotomizes patients' outcomes into good versus bad in terms of modified Rankin score at 90 days. Studies have also showed that moderate blood pressure control, in most studies defined as systolic blood pressure goal of less than 140 millimeters of mercury post-endovascular treatment, may be associated with best clinical outcomes in terms of functional outcomes at 90 days, as well as hemorrhagic outcomes, mortality, and the rate of requirement of hemicraniectomy in these patients. So there is growing evidence, albeit observational, that moderate to low blood pressure goals for endovascularly treated patients may be associated with good outcomes. However, if this is causal versus a non-causal association is yet to be determined. Randomized trials are ongoing. We have one randomized trial completed in this space called BP Target Trial by Michael Mazzucchi in France. This multi-center open label clinical trial basically included patients who were successfully treated with thrombectomy for an ICRM1 occlusion and randomized them into two blood pressure goals, either 100 to 129 millimeters mercury or 130 to 185. And they wanted to evaluate the effects of these low versus standard blood pressure goals on primary outcome of radiographic intraparenchymal hemorrhage on brain CT at 24 to 36 hours. This was a neutral trial in that lower blood pressure goal did not actually improve the rate of any radiographic IPH on CT at 24 to 36 hours, with no difference in actual functional and neurological outcomes in terms of MRS and NIH stroke scale as well. As I mentioned, there are ongoing studies. Craig Anderson is conducting one in China. We are conducting one here in the United States. It's called BEST2 to evaluate the safety of lower blood pressure goals in about 120 patients. We are randomizing them 1:1:1 in blood pressure goals of 180, 160, and 140 using nicardipine as first-line agent. And this goal is maintained for 24 hours after successful EVT. We have completed enrollment in this trial and we'll be reporting results pretty soon, so we're excited about it. In conclusion, as I mentioned, hypertension management and acute ischemic stroke should be thought about in terms of what kind of reperfusion treatment is being offered or planned for the patient. Just to reiterate what I have been through before, when no intravenous or endovascular intervention is planned, then the blood pressure goal needs to be less than 220/120, in the sense that do not treat the blood pressure unless it goes above 220/120, unless there is another comorbid medical condition that requires more aggressive blood pressure management. This is again to sustain that penumbral tissue using permissive hypertension concept. When patients are treated with intravenous thrombolysis or endovascular treatment, these goals are 185/110 pre-treatment and 180/110 post-treatment for 24 to 48 hours. Similar goals when patients are treated with both. There are no different goals for those patients. Again, preferred agents are nicardipine, clevidipine first, just because of their effect on blood pressure variability and reduction of it as compared to labetalol. Again, to reiterate the fact that lower blood pressure it means lower hemorrhage in intravenous thrombolysis treated patients. This is yet completely not clear for our endovascular treated patients. Important to also remember that lower blood pressure does not mean improved outcomes in intravenous thrombolysis treated patients. This is still a topic of active research in endovascular thrombectomy patients. And again, we should have some really exciting results soon. Thank you.
Thank you very much, Dr. Adams and Dr. Eva, for this important topic. Actually, the management of hypertension, the setting of stroke is very, very important. And actually, it's, I guess, everyday practice. As we mentioned to our attendees, we will postpone the questions to the end of the session. We have a whole session for the Q&A. So please, if you have any questions, just put it in the Q&A box. And again, I welcome you to the EDS chapter of MENASO Education Academy, Cerebrovascular Grand Round 2022, organized by the MENA Stroke Organization and endorsed by the American Stroke Association. Now it's time to introduce our prestigious guest, Dr. Stephen Massey. He's a professor of neurology at the Hospital of the University of Pennsylvania in the division of the vascular neurology. He pursued his undergraduate degree at Yale University and then received his MD from the University of Michigan School of Medicine. He performed his internship and neurology residency at the Hospital of the University of Pennsylvania, where he then completed a vascular neurology fellowship there and joined the faculty in 2004. He has served on numerous U.S. national committees, including the American Academy of Neurology Guidelines Development Committee, where he helped author practice guidelines and served as the vice chair from 2016 through 2019. He also served on the American Heart Association Stroke System of Care Committee, which oversees the Get With The Guidelines Quality Improvement Database. He has received many awards for his teaching, including the Penn Pearls Teaching Award from the Perelman School of Medicine and Department of Neurology Resident Teaching Award. He was also selected to receive the American Academy of Neurology Mitchell-Pesson Stroke Leadership Award in 2011. Welcome, Dr. Stephen, and he will present an important topic about the BFO and stroke, which I guess it's a very hot topic today. So I also encourage our attendees, if they are having any questions, just to put it in the Q&A.
Thank you, Professor F. It's a great pleasure to be here. I truly appreciate the opportunity to speak with you. I'm going to go ahead and try to share my screen. And you can all see that, I hope.
Yes, doctor, we can see this.
Thank you for confirming that. All right, so the title of my talk is PFO and Stroke Prevention, Some Closure, which refers to the fact that we really didn't know what to do with patients who had a stroke and were found to have a PFO for many, many years. But there's been an accumulation of data. There's been 6 randomized trials, which I will go through quickly today. And it turns out that we should be probably offering closure to some select patients, and we think that's going to benefit them. So we'll go ahead and get started. These are my disclosures. The relevant ones are the fact that I did enroll patients in the GORE Reduced PFO Closure Trial, and I have a investigator-initiated grant with that company looking at neurologic outcomes from aortic surgery. And I also wrote a couple articles on PFO and stroke for Up to Date, for which I receive royalties. We'll start with a case. We had a 54-year-old woman who presented with a small embolic appearing left hemispheric stroke with mild symptoms, fortunately. She did have some vascular risk factors. She was a smoker. She had hyperlipidemia, and she had been on hormone replacement therapy transiently before this happened. She had a very thorough workup. Echocardiography showed normal ejection fraction. She had a mildly dilated left atrium and a PFO with right to left shunting at rest. We performed AFib monitoring, which was negative, and we were then asking how we should manage this patient going forward to prevent another stroke. And so we'll talk about that. I often talk to cardiology groups, and when I do that, I point out that ischemic stroke is different from myocardial infarction. Stroke is really challenging. It's a morass. The etiology is diverse and often uncertain, and that is in comparison to heart attack, where the pathophysiology is relatively homogeneous. Of course, there's many ways you can have a stroke, and oftentimes we don't know what specifically caused it. Importantly, the management for stroke prevention going forwards for secondary prevention really does depend on what the cause of the first event was. As much as possible, we try to tailor the treatment to prevent the stroke type that you had previously. And TIA is even more challenging because transient neurologic symptoms certainly may be caused by vascular occlusion. That's temporary, but other things can cause temporary neurologic symptoms as well. So not every TIA or suspected TIA is truly a vascular event. When you look at the different kinds of subtypes or causes of stroke, these are some old data, but it's still pretty accurate. You'll see that about 20% are caused by large artery atherosclerosis, about 20% are due to intrinsic small vessel disease. About a quarter are attributed to cardioembolism, high-risk cardioembolism, such as AFib. 5% are in this other category, which would be dissection, hypercoagulability, drugs of abuse, sympathomimetic drugs. But you're left with a large number of patients, about a third, 25% to 30%, that are cryptogenic, and we're not sure what caused the stroke, despite an appropriate and thorough workup. The question is, how many of these may in fact be caused by a PFO when it's found? So to go back in time a little bit, the foramen ovale was initially described by a surgeon in France. He was actually Italian. His name was Leonardo Battalo, and it was called Battalo's foramen. And then in the late 1800s, Dr. Cohnheim, who worked with Virchow, he was a pathologist, and apparently he was taking care of a woman who died of a middle cerebral artery stroke and also was found to have a deep vein thrombosis on autopsy, as well as this foramen ovale. And he posited that perhaps the foramen ovale allowed a venous blood clot to paradoxically transition into the arterial circulation, then causes middle cerebral artery stroke. So he was a very smart person, obviously. This is a TEE view of what a PFO looks like, in case you haven't seen it. The white blob here in the bottom left corner is the right atrium, which is opacified with the bubbles that have been injected, and above that is the left atrium, and that line there between them would be the atrial septum. And you will see the bubbles inject into the left atrium from the right atrium as the patient bears down. So that's a pretty good example of what a PFO looks like on TEE. It's a very common finding. Autopsies, cadaveric studies suggest that PFO is present in somewhere between 17 to 29% of the population. In vivo studies, they vary, obviously, but the best study comes from Mayo Clinic, where they did TEEs in volunteers from the population, the local population, almost 600 patients, and they found about a quarter of them had a PFO. The autopsy studies are interesting also in that they show that the incidence of PFO goes down over time, or prevalence of PFO goes down over time as people get older. Presumably that these adhesions are continuing to form and the PFO gets smaller or closes. That's possibly it. Some cardiologists have suggested that perhaps patients with PFO are dying at a younger age. I don't know if that is a fair conclusion. But here is an example of an atrial septal aneurysm, which is another common finding in the atrial anatomy, which also has been associated with stroke. And you can see this atrial septum is just jumping around like a rope. It's really quite impressive. So when you see an atrial septal aneurysm, frequently, most commonly, it is associated with right to left shunting, at least 75% of cases. And when you do have an atrial septal aneurysm, the degree of shunting tends to be larger than if you don't have an atrial septal aneurysm with the PFO. It's not as common though as PFO. It's about 2% of the general population seen on TEE. And it is more commonly seen in patients with stroke. And that's what has been shown for PFO. So this is an old study now. This is a meta-analysis from 2000 that looked at case control studies that were looking for PFO, the incidence of PFO in patients. And if you were young, if you were under 55 years of age, and you had a stroke compared to patients who didn't have a stroke, the odds were threefold that you would find a PFO. So there's an association between young stroke patients and a higher incidence of PFO. The cause of stroke is most commonly this paradoxical embolization that was initially described by Dr. Cohnheim. When we look for venous clots, it's variable, honestly, how often we're going to see them. Studies have ranged from 2 to 20% or so will be found to have proximal vein clot in their leg and also potentially in their pelvis. I think the most important data sort of supporting the paradoxical embolism hypothesis comes from patients with pulmonary embolism. About 60 patients in France presented just with pulmonary embolism. That was a presenting symptom and sign, and they all had TEE and they all had MRI. And the patients, 10% of them or 6 of them had infarct on their MRI, acute infarct. The TEE showed PFO in about a quarter of this population, as you'd expect. And they were almost all, the infarcts then were all seen in the patients with PFO. So clearly patients that are having clot traversing the right side of the heart, if you have a PFO, there's a significant risk that it could lead to infarct in the brain as well. This is a classic picture from New England Journal of Medicine, the image in medicine, showing a trapped thrombus in the PFO, so transiting the foramen ovale, but it was so big that it got trapped there. And this is what it looked like when they pulled it out. So that was really an impressive image for sure. Importantly, PFO is low risk for stroke recurrence. If you look at this meta-analysis of 15 studies for medically treated PFO patients, the rate of stroke was about 1 to 2% per year. And that has been seen really in all the prospective studies. It's not a very, very high risk of stroke, and it makes intuitive sense given how prevalent PFO is in the adult population. You'd think we'd be seeing a lot more strokes if it was a very high risk mechanism. And again, these are patients who've already had a stroke and presumed to be due to the PFO, the risk of recurrence is low. So we have a number now, we have 6 randomized trials that have addressed PFO and PFO closure, specifically. I think what's important to note here, if you look at when these trials began enrolling and when they completed, you can see that many of them took a very, very long time. So it was challenging to enroll patients in these studies. One of the challenges is just getting a patient to agree to a randomized intervention or not. Obviously, patients want to have autonomy and make their own decisions about when they get procedures. So that was challenging. But the other challenge was that PFO closure was occurring off-label outside of trials, which really did stymie enrollment. And that was very challenging, particularly early on as the first 3 trials or so were ongoing. So we'll go through these very quickly. The first trial that got published was the CLOSURE 1 trial. Patients were under 60 years of age. They were randomized to medical therapy, which could have been aspirin or warfarin or both, versus the StarFlex closure device. And this study was clearly negative. So it was a primary endpoint that was a combined of stroke, MI, vascular death, no different between the 2 arms. But if you just look at stroke, there was absolutely no difference whatsoever, importantly. And there were more complications in the patients who underwent closure with this particular device. So AFib was more common. There were more vascular complications from the catheter, and there was more bleeding as well. The next year, there were 2 studies published with the Amplatzer PFO closure device, which, speaking to any cardiologist, they would have said prospectively that they definitely prefer the Amplatzer device for ease of use and safety. So the StarFlex device was not well liked at that time. But these Amplatzer studies, the first was PC trial, which was just over 400 patients, all under 60 years of age. They looked at a primary outcome combined of death, stroke, TIA, or peripheral embolism. And they followed patients for a long time because it took a long time to enroll. Primary endpoint was not statistically different, but favored closure, 3.4% versus 5.2%. Hazard ratio 0.63, not significant. You can look at survival curves here. If you look at just stroke, it occurred in 1 of the patients who underwent closure versus 5 medically treated patients. Hazard ratio estimate of 0.2, not statistically significant, but favoring closure overall. The next trial that was published is the RESPECT trial, which was also an Amplatzer study. I'm showing just the data from a longer term follow-up of that same study because they did continue to follow patients. So this was a larger trial, 980 patients, again, less than 60 years of age, randomized to Amplatzer versus medical medications, which could have been aspirin or Coumadin. They just look at stroke, which is important because that's the only thing that PFO closure is likely to benefit. And they followed patients in the end for almost 6 years, which is a remarkably long trial for sure. The initial publication only followed patients for a median of 2.3 years. Given the long duration of follow-up, unfortunately, they did lose a lot of patients along the way. And it was just about a quarter overall, but it was imbalanced. If you were randomized to medical therapy alone, almost a third of those patients were lost at the study end versus 20% in the closure arm. So it's not random when they lost follow-up. But just looking at the primary outcome of stroke, there were fewer strokes in the patients who underwent closure compared to medical therapy, about 0.6% to 1.1% per year, if you look at it that way. And the hazard ratio was 0.55, the p-value just under 0.05. And here again is the survival curves. What's interesting is that the initial publication occurred when they were trending towards a strong trend towards benefit, p-value 0.08. And then with further on, you can see the curves start to come together again, like there's a belt put on the waist there. And they had actually analyzed the data at that point for the FDA, and it looked a little bit worse, but then they continued to follow patients again and stopped it now that it was significant. So I think those three analyses are worth mentioning. And some other caveats. So there was this high loss to follow-up, low event rates, again, because PFO is low risk for stroke recurrence, but still causes stroke, presumably. And we analyzed it, or they analyzed the data 3 times, which if you're doing that statistically, you should really have a lower p-value threshold than 0.05 for claiming statistical significance. And then they really had few patients that were followed beyond the 7 years when those curves really started to diverge again. But subsequent to that, there were other trials that have come out which are very supportive of PFO closure. So the first was the Gore reduced trial, 664 patients, had to have embolic appearing strokes. So no small deep strokes, all had to be embolic appearing, randomized 2-to-1 to closure versus medical therapy. And they followed patients for just over 3 years. And here you can see the hazard ratio was 0.23, strongly significant. There was 1.4% had strokes in the closure arm versus 5.4% in the medically treated arm. They did also show, however, that AFib is more common with closure, again, 4.6% versus 0.9%. So clearly a positive trial for PFO closure in terms of stroke prevention. The closed trial, published at the same time, was 663 patients under 60 years of age who had to have what they consider to be a high-risk PFO, so a large shunt or atrial septal aneurysm. And this was a 3-arm randomization, either to aspirin or anticoagulation, predominantly with Coumadin, or PFO closure. And they were agnostic to the type of PFO closure device. Any European CE mark device was allowed, but most of these devices were the Amplatzer device, just over half. And most of the anticoagulation was with Coumadin. So this, again, was strongly positive, comparing antiplatelet to closure. After 5 years of follow-up, there were no strokes in the closure arm versus 14 in the antiplatelet arm. Again, AFib was more common, 6.6% versus 0.4%. The hazard ratio was 0.03 for stroke prevention. So that's a really compelling story for sure. When they looked at oral anticoagulants versus antiplatelet therapy, this was a smaller comparison, because if you weren't going to tolerate anticoagulation, you couldn't be included in this analysis. And so it suggested that there was a benefit of anticoagulation over antiplatelets. The hazard ratio 0.43, but not significant. And then they didn't perform this comparison in the publication, but if you look at it, the stroke rate did not appear to be statistically different between anticoagulation versus PFO closure. There were 3 strokes in the anticoagulation arm and 0 in the PFO closure arm. And then finally, there was a relatively smaller trial in Korea from 2 sites there, 120 patients. Again, they had to have an embolic appearing stroke, and it had to be a high-risk PFO, meaning a large shunt and or atrial septal aneurysm was present. And they were randomized to the Amplatzer device or medical therapy with antiplatelet or anticoagulation. Strokes occurred in 10% of the medically treated arm versus none of the patients who underwent closure. Importantly, there did not appear to be blinded adjudication of events in this trial, was one of the methodological concerns. All right, so overall, though, some other concerns are that all of these trials were open label endpoint ascertainment. So the patients knew what they got, obviously, in terms of treatment. The doctors who were treating them knew what they got in terms of treatment. And so when events were referred for adjudication, there's potentially concern that there could be bias. Many of the later trials tried to modify or at least modulate that by screening all patients for symptoms of stroke and then looking carefully. But I think it's important to note that concern is there. And the defense PFO trial, again, no blinded adjudication. So even the adjudication of events, they knew what they were on. All these studies had high loss to follow-up and high rates of crossover, which undermines the randomization, and low event rates overall as well. So looking at a meta-analysis of closure trials, this was published as part of the American Academy of Neurology's guideline published in 2020. Looking at all these trials, the absolute risk reduction for stroke was about 2/3%, 0.66% per year. And if you look at a 5-year time horizon, that's a 3.4% reduction in the risk of stroke. Not bad. Number needed to treat of about 29 to reduce 1 stroke at 5 years. And what's important to note is that the time horizon should probably be much longer than that. These are younger patients. They're going to live many, many, many years. And so I think that this is probably a clinically important effect. A couple other interesting things as you look at this graph here, you can see that as time went on, the point estimate for benefit of closure seemed to grow. In the later trials, there was greater benefit of PFO closure, which is certainly very interesting. And so why, in particular, did these last 3 trials show such a benefit? I think there's probably 3 good reasons for that, is that they selected their patients more carefully, and they only allowed for embolic appearing strokes, no small, deep strokes. More importantly, they chose people who had high-risk PFOs with atrial septal aneurysm or large shunts. And then the third reason that's really important is that the off-label PFO closure was not occurring as frequently as it was in the past when the other trials were ongoing. And so perhaps those patients who were most likely to benefit were initially being withheld from the trial. They were just getting closed off-label. But finally, they were getting randomized in the last trial. So maybe those are the reasons why we see this change over time. Subsequent to that, the meta-analysis also for the AN also did look at adverse events. So complication rates of the procedure was under 4%. Most of these were not severe. And new onset non-periprocedural AFib, so beyond 30 days after the procedure, AFib was more common in patients who underwent closure, about 0.36% per year for these patients. And then looking for heterogeneity of effect in the subgroups, there did not seem to be any difference if you were under 45 or over 45 up to age 60. All patients benefited equally. Shunt size did matter. And so as I was talking about in terms of why these later trials benefited more, patients with large shunt were more likely to benefit from closure. Whether an atrial septal aneurysm was present, the point estimate suggests slightly maybe a greater benefit in those patients, but not a statistically significant interaction. Whether you were given antiplatelet medicine or anticoagulation did matter. So the benefit of closure is clearly there compared to antiplatelets, not as clearly present if you're given anticoagulation, acknowledging that the confidence intervals are wide and there was not a positive interaction term for this. And then finally, if it was embolic appearing versus small, deep strokes, again, the interaction was there that you're likely to benefit. It's embolic appearing stroke to begin with, because presumably the PFO is more likely to have been involved with the first event. So the conclusion of that guideline in 2020, for the first time, the American Academy of Neurology was recommending PFO closure for patients under 60 who have a PFO, embolic appearing infarct, and no other mechanism of stroke identified. Subsequent to that, in late 2021, there was a very important patient-level meta-analysis performed that looked at all of the randomized PFO closure trial data. So this is 3,700 patients, over 3,700 patients, median age 46. Vascular risk factors were not common, but a third of them had hyperlipidemia, quarter had hypertension, 6% had diabetes. This particular analysis was looking at the utility of the ROPE score in the Pascal classification, which I will show you right here. The ROPE score is a way to determine whether the PFO was likely to be the cause of a prior stroke. And you can calculate this by adding up the numbers. If you have no history of these typical vascular risk factors, it's more likely that the PFO was involved. So no history of hypertension, diabetes, or a prior stroke, which again speaks to the point that PFO is generally low risk for stroke. And if you're accumulating lots of strokes quickly, it maybe isn't the PFO and something else is going on. And then smoking, if you're a non-smoker, also gets you 1 point. And then embolic appearing stroke, cortical infarct on imaging also makes it more likely that the PFO was the cause of the stroke. And then younger people, more likely that the PFO would be involved. And so you get 5 points if you're under 30 years of age. And then you subtract 1 point for every decade above that up to age 70. So you can add these up, and the higher the number, the more likely it is that the PFO was related to the first stroke. And then the Pascal classification system takes the rope score and also looks at the echo findings to see whether it's a high risk PFO or not, and puts them together. And if you are a high rope score, if you're not a high rope score, meaning 7 or higher, so if you're 0 to 6, unlikely that the PFO is related to your stroke, and you don't have high risk PFO features such as a large shunt or atrial septal aneurysm, it is unlikely that the PFO is related to your stroke. If you have one or the other of the high rope score or high risk features, it's possible that the PFO is related. And if both are present, it is probable that the PFO is related to your stroke according to Pascal. So how did the Pascal and rope scores do in the population of patients in the randomized trials? Here in the top panels here, for the rope categories less than 7 versus greater than 7, there is an interaction. For greater than 7, there's clearly a stronger benefit of PFO closure. And then for the Pascal category, it becomes even more apparent. If you're unlikely to have a PFO attributable stroke because you don't have high risk PFO features and your rope score is 6 or less, there's no benefit. There seems to be no benefit of closure, whereas possible or probable Pascal categories clearly benefit. And the probable category benefited hugely with a hazard ratio of 0.9, 90% reduction, 0.10, excuse me. And then you can look at the absolute risk reductions as well here in the lower panel here, where again, if the rope score is less than 7, no clear statistical benefit on the absolute risk reduction, whereas clearly in the Pascal category is possible or probable that there's a benefit. So this seems to be very helpful to determine who should and should not be getting their PFO closed. And Pascal, therefore, is something we should be looking at. It's also important to note that by Pascal category, the risk of AFib varies as well. So if you are unlikely that the PFO was the cause of your stroke, the risk of AFib goes up dramatically. 9.4% of the patients had AFib compared to 2% without closure. And that risk difference was 7.5% relative risk of almost 5-fold. And that's lower if it's a possible or probable AFib attribution. I'm sorry, PFO attribution for the stroke cause. And this is true if you look at AFib around the time of the procedure or beyond that, beyond day 45. Clearly, the risk of AFib goes up as the Pascal category goes down from probable to possible to unlikely. And I'm going to briefly end talking about medical therapy for PFO. In patients who do not get their PFO closed, should we be giving anticoagulation rather than antiplatelets? This meta-analysis was published as part of the RESPECT-ESIS paper, which is the last one to look at anticoagulation versus aspirin in patients with PFO. And the meta-analysis suggests that anticoagulation may be a little bit better, but it's not a significant reduction. And so it's not clear that we should be giving all patients who don't get their PFO closed anticoagulation versus aspirin. Importantly, most of these trials enrolled older patients. If you look at PICS, Navigate, and RESPECT, most of these patients were over 60. So I think this is unknown. We don't know what the answer is, whether we should be giving patients anticoagulation if they don't undergo closure. There's no proven benefit, and given the ease of use and comfort using aspirin as opposed to a DOAC, for example, most of us are still using aspirin primarily. So finishing up here, back to the case of this 54-year-old woman with embolic appearing stroke. She had a PFO with shunting at rest. Should we recommend closure for her? She had some modifiable risk factors in that she was a smoker and she had hormone replacement therapy, which clearly puts her at risk for venous clotting. And she was very happy to stop both of those activities to reduce her risk. We talked about PFO closure as something that might also benefit her additionally to that, but she was loath to undergo procedures and didn't want to have a device in her heart. And this case, I think, really exemplifies the fact that there are going to be subjective decisions by patients based on their values and what they value in terms of risk of stroke versus risk of a procedure. And so she elected not to undergo PFO closure. And I thought that was reasonable for her, particularly given that she had other risk factors that we could address. So to conclude, PFO is a common finding in adults. It is not a high-risk stroke mechanism, but it is a stroke mechanism. We think that closure benefits select patients, but it's important that you rule out other high-risk causes before proceeding to closure. It's not a stat issue. You want to do that thorough workup. And if you find an alternative high-risk etiology, that's probably more likely to be the cause and should be the issue that gets addressed. PFO closure reduces stroke risk in patients with possible or probable PFO-associated stroke per Pascal. So if you're under 60, no other cause, embolic appearing, these are patients that you'd want to consider PFO closure. In other patients with PFO, the benefit is less clear. So many patients that we see in the clinic are not the same patients who are enrolled in the trials, and that external validity of the trial is something that we always wrestle with. But clearly, some patients did not benefit, based on this patient meta-analysis. So who shouldn't be closed? I think if they've never had an event, I really do not think you should be doing this for primary prevention. If there's an alternative higher risk stroke mechanism present, if you're older, if you're over 65 to 70, particularly with vascular risk factors, I think at this point we should not be offering closure to those patients. The fact that there was no heterogeneity looking at under 45 versus over 45 up to age 60 suggests that maybe there are patients over 60 who benefit, and I have recommended it for some patients in their lower 60s who are very healthy. I think that's reasonable, but it should be done cautiously. If it's a small vessel appearing stroke and there's vascular risk factors present that would explain that, I don't think PFO is likely to be the issue. If there's small shunt, absent atrial septal aneurysm, the rope score is low, that's the unlikely Pascal category. Those patients should be closed. The last one's really challenging. If a patient requires lifelong anticoagulation anyway, should you also be offering closure? I see no evidence in the literature that that patients also benefit from closure if you're anticoagulated, but it is something that cardiologists certainly consider, and I think it's worth a discussion with patients. So going back to this distribution of stroke etiologies we talked about in the past, we used to say up to 30% were cryptogenic. It's probably more like 30% are cardioembolic, and about 5% of these are due to PFO, and certainly is something that we see a lot of. I'm sure everybody does, and it's always challenging, but an interesting area of stroke neurology. So thank you very much for your time, and I do appreciate it. I'm happy to answer any questions.
Thank you very much, Professor Messi, for this wonderful presentation and shedding light on how should we stratify patients with PFO. I would like to extend my thank to the previous two speakers for a wonderful talk. Let me take the opportunity by being chairman and start with the questions to Professor Messi. With the trials tested antithrombotic, in particular aspirin and warfarin compared to the closure, and with the new NOACs being game changers, in particular for atrial fibrillation, and patients on warfarin, we know that they're most of good amount or good percentage of time they're not adequately anticoagulated, and those events are embolic. So, what's your thought about NOAC versus closure? And is there any trial testing that?
So that's a wonderful question, and there are no good data that I'm aware of that have looked at the NOACs versus closure in this population. The ESIS trials, Respect ESIS and Navigate ESIS, did look at NOACs versus aspirin and some of those patients had PFO that they weren't systematically looked for, and they did not show any clear benefit of anticoagulation over aspirin, which was disappointing to me. I was hoping that we would see an effect there based on the other data that we had. And again, these are relatively older patients, not younger patients with PFO. So I think that this is really an uncertain area in PFO stroke clinical practice that I don't know what the right answer is. In general, I don't treat with NOACs unless there's a good indication. If they have a DVT, they need to be on a NOAC. And if they need to be on it for the rest of their life because it was an unexplained, unprovoked DVT, I don't push hard for PFO closure in those patients. As I said, it's not clear that closure benefits them on top of anticoagulation.
And on a practical point, is the TCD helpful sometimes to stratify patients, and what's your experience with that?
So I think TCD can be helpful for risk stratification. It's measuring, the end organ that you're most interested in, and I think it makes it a little bit easier to measure the degree of shunting. I've heard from a lot of cardiologists that they have a hard time estimating shunting on the echo. They don't always get a good view of it. So I think that's a good reason to look at TCD, but I think it's really adjunctive in that the TEE looks at the septum and you can confirm that there's a PFO there, and it's not an atrial septal defect that may need to be closed for other reasons, or some other high-risk cardioembolic source like a fibrillastoma. You get a better look at the aortic arch if there's athero present. So I do think that the TEE is necessary to look at the atrial anatomy and to look for other causes of stroke. If you're not sure you got a good look for a PFO, I think the TCD can be helpful in that way. And it can certainly look after also to make sure that the PFO is closed. And also I didn't mention this, but if you see a shunt on the TCD, you don't know if it's cardiac. It might be
cardiac or
it might be a pulmonary AVM, which I've certainly seen multiple times now, which we think contributed to somebody's stroke risk.
Thank you very much. Very helpful. I have a questions to Dr. De Haven regarding the blood pressure control with the intracerebral hemorrhage. With those trials taking heterogeneous group of all hemorrhages, any specific insights regarding, hypertensive, subcortical, in terms of benefit of tighter blood pressure in those on those population, and along the same lines, using radiological information like the spot sign and the blood pressure control on those patients?
Yeah, great question. And I agree, they were heterogeneous by design, essentially, excluding large hemorrhages for obvious reasons, just that their mortality is so high in ICH. But, they primarily, though, did enroll deep hemorrhages because you did have to have an acute hypertensive response to get into the study. So in the subgroup analyses, they did cortical versus deep hemorrhage, looking for an interaction with treatment, and didn't demonstrate it in either study. Probably those are underpowered. And, some patients who have more cortically based hemorrhage had it because of hypertension. Not all lobar cortical hemorrhage is amyloid or, masses or AVMs. Some is just hypertensive. To answer your question about specific radiologic characteristics, there have been secondary analyses that looked at various components, both location of hemorrhage. I can't recall one that's looked at the spot sign, but there are ways to slice and dice the data where it seems that there's more effect to lowering blood pressure aggressively. I take that all with a grain of salt. I mean, speaking as somebody who publishes a lot of post-hoc analyses, it is something that you might design a clinical trial around and find that there is no effect later. Personally, if I see a spot sign, I am going to get their blood pressure under very tight control. Now, I may not shoot for 120 systolic, but I'm going to get it under 140, and I'm going to get it there quickly, and I'm going to keep it there.
Thank you very much. I'll move the mic to Professor Hani.
Thank you, Dr. Adel. Again, I will thank our three speakers for this comprehensive presentation and very important topics. Now I have a question from Patty. I guess this is for Dr. Eva. If the first 2 doses of IV labetalol is ineffective in lowering blood pressure pre-IVT, does one switch to IV CCP, or can one use labetalol infusion? If so, what is the maximum recommended infusion dose?
So I will say for our own practice, I usually, if the patient's blood pressure is higher than the recommended goals for initiation for thrombolysis, I usually just go ahead and ask for a calcium channel blocker drip preemptively, anticipating that that patient will need it post thrombolysis as well, because the goal difference is merely just 5 millimeters of mercury, and it's always the rebound effect from bolus doses, especially beta blockers and things like that, is just oftentimes not enough to maintain blood pressure goals post thrombolysis. It's absolutely critical to maintain that to prevent hemorrhagic complications. So I would say that usually, and probably I can say for most of my colleagues, the practice is to just go ahead and order a calcium channel blocker. It takes a minute or two to get it delivered to the ED in the United States. We don't use labetalol drip as often. As Malala have used it in ICU settings, but it's just sort of not something that our EDs are usually used to doing. I haven't used it before, so I can't comment on the max dose of labetalol drip, but nicardipine is maxed out at 15 milligrams drip dose. But just labetalol drip is not something that we use very commonly.
Okay. I guess in the same context regarding the blood pressure, this question can be directed, of course, to Dr. Eva and Dr. Adam regarding the effect. I mean, Aaron is asking, the blood pressure is a rather crude measure of perfusion. Any studies, guidelines on influence of other hemodynamic parameter?
Yeah, I think it's a great point. I think it's a chicken or egg question that I think everybody is trying to chase, whoever studies blood pressure goal these days. And I would say that with novel perfusion imaging availabilities, including post perfusion imaging, I think that the field will move towards understanding if blood pressure is associated with perfusion, microcirculatory reperfusion, or no reflow phenomenon, et cetera. So I think that that's a lot of movement in that field right now. A lot of people are interested in that question. But generally, our understanding currently is limited, but also correct in that the hypertensive response is reactive usually to maintain cerebral perfusion. And so that is why whether lowering blood pressure is safe is the first question that we need to answer, especially looking at the microcirculatory level, and just to make sure that we're not, depriving brain from this natural reactive phenomenon that the body is reacting to maintain cerebral perfusion. I know Adam does a lot of work in this area as well, so I'll let him speak.
Yeah, and gosh, every time that I thought that I had figured out what the optimal blood pressure would be, another analysis comes out that humbles me, or in particular in the imaging. Early in my career, I was very interested in augmenting pressure in acute ischemic stroke patients, those with large vessel occlusions in particular. And then I saw some research that David Liebeskind at UCLA did showing that if you augment pressure, the contralateral brain vasoconstricts and you can rob the penumbra of collateral flow. It is a very sort of specific case example, but it just highlights the concept that the brain and autoregulation in the brain are so complex. And I ultimately think that this is going to be a category of personalized medicine, that every patient will have their own specific hemodynamic goals. Imaging will play a role in that, and probably premorbid status as well. But there are a lot of interesting trials ongoing. I do ultimately think, though, that there won't be a one-size-fits-all.
Great. The next question from Mohammed El Mirza. I guess this is directed for Dr. Stephen. Can TTE be done with bubble study to detect PFO, and what is the sensitivity?
So it certainly can be done, and we usually start with that. It is less sensitive than TEE as well as TCD. I think on average in population, the PFO rate is about 15% on TTE, whereas it's 25% on TEE. So I think it's important to know that you're going to find fewer of them on the TTE. And if you really want to look carefully, I think a TEE and or TCT is indicated for sure. But it's reasonable to start with that.
I have a question actually in this respect, because, you know, in the routine, of course, all of us will do the TTE, but I mean, when you will go for TEE on assumption that the patient is having a thrombus, which can be visualized on the TTE, or on assumptions that he's having PFO, all the cryptogenic should be done, the TEE, or even all stroke patients should be done in the context of TEE. I mean, what's your opinion on, or it varies from one center to another?
It is variable. I think it's a really good question. And, you know, when I started and completed my training and was practicing, we used to do TEEs all the time. And it's really fallen off a fair amount. Part of it's due to the fact that AFib monitoring, and we've appreciated that AFib, you know, occult AFib is an issue and certainly causes some of these strokes as well. But I think the TEE is very helpful. And all the patients who underwent closure in the trials, they all had TEEs. As I said, it gets a much better look at the atrial anatomy. And now that we know this, you know, the Pascal score and classification, looking at PFO, high-risk PFO is really important. And I think you're going to get all the information on the TE. And then again, looking for the stroke, other stroke mechanisms besides PFO, the TE is indicated. So, and the cardiologists I work with, they all insist on a TE before they'll do closure, again, to get a look at the anatomy, to make sure they know how they're going to approach it, and whether it is, you know, something that they can easily close or not.
Yeah,
So
but I mean,
we're doing it.
In the context of stroke in general, you will do it for just the cryptogenic, or you will do it for whole stroke, any stroke patient?
Yeah, young cryptogenic stroke patient, particularly one where I'm concerned about PFO, I will certainly do it. In older cryptogenic stroke populations, now I'll do AFib monitoring first, and at least 4 weeks of that, if not longer. And if that is negative, then I often do recommend a TEE. Again, I get a better look at the valves, I get a better look at the aortic arch. Looking for thrombus in the atrium in particular is going to be better on TE as well. So I'm doing it more selectively, but I'm definitely doing it. I don't know if Adam and Eva want to talk about their experiences, because I do think it's variable now.
You have anything to add, Dr. Adam or Dr. Eva, in this respect?
Are you doing a lot of TEEs lately?
No, I think it's TE decisions are very, very individualized. I guess I probably goes for all academic centers. It's a battle between services kind of a situation. So I can't say that we're nowhere near protocolizing it and agreeing upon a protocol yet, but
yeah.
Okay. So this is again for Dr. Stephen. I guess those 581 patients in the studied with the TEE did they have a stroke?
So they didn't. These were randomly selected from the population. They were calling people and asking for volunteers in Rochester, Minnesota. So importantly, it's almost entirely white population, Caucasian population in the Midwest. But they were not selected because they had a stroke. And I have to go back and look at the paper, which was from 1999, to see if any of them had a stroke. I think some of them did, but it was a small percentage. So they were just randomly selected from their population.
Okay. A question from Sidra. This is for Dr. Eva. In a patient with ischemic stroke with concurrent myocardial infarction or renal dysfunction, how low can we take the blood pressure safely?
Yeah, great question. I don't think that there is a data-driven answer to that that I can give you that's published. I think that would be considered, at least from a guideline standpoint, to be a concurrent medical condition that requires a lower blood pressure target. And then I think that it would be a conversation with the respective services, cardiologists, nephrologists, et cetera, as to what is a safe blood pressure goal from systemic perspective. And then I guess it would sort of be arriving to an agreement kind of a situation. But I don't believe that we have a set answer from good set of published data regarding what to do for as a standard across the board.
Question to Dr. Stephen: any indication or justification for screening people for PFO people with other risk factors of stroke, or those with other organ anomalies? Dr. Stephen, we can't hear you.
I apologize. Can you repeat that question one more time? I didn't quite hear it.
Any indication or justification for screening people for PFO, people with other risk factors of stroke, or those with other organ anomalies?
So I don't think we should be screening for PFO if they have other risk factors for stroke. For example, they're hypertensive, diabetic, high cholesterol, smoker, and they're 70. I don't think I do a bubble study in that patient, and I try to tell my residents, my trainees, to not order bubble studies on all of my patients. Do it selectively in the ones that you're likely to act on that data. So I hope that answers the question. I'm not sure if I did.
Again, this is for Dr. Stephen regarding the AF with PFO closure. Yeah. So Patty is asking why AF would occur more frequently in healthier heart post-closure.
That's a great question. So I do think that the device is contributing to the AFib rate. First of all, that's clear based on the studies that show AFib is more common once you've had closure. But the reason why in the unlikely category for the Pascal is probably age related. We know that AFib incidence increases with age, and your susceptibility to it increases with age. And so the ROPE score specifically, you lose points as you get older. So once you're above 60, your ROPE score is already in the unlikely category. You're down to 6. And so I think that is why the AFib rate was higher with closure. We know the device does it, and we know that older people are more likely to get AFib, and there's going to be an interaction between those two.
Again, for Dr. Stephen, I guess coming 3 questions for Dr. Stephen. If we decide from Gamal, if we decide to PFO closure, can we stop medical treatment?
I like that question because I fight against cardiologists all the time on this. I definitely have seen that in practice. People have been told they don't need to take an aspirin once they get their PFO closed, and it's been 6 months. I strongly argue against that. There is always a chance that the PFO was an innocent bystander and it wasn't the cause of the stroke. And that if you had a venous thromboembolism that led to a stroke, you're at risk of venous clotting, and aspirin is going to help against that as well. And DVTs and PEs can be devastating. Obviously, they can be fatal. So I argue that patients should be on aspirin lifelong, barring a contraindication. If they have a bleeding contraindication, that can be reassessed. But that's my practice, and I strongly advocate that way. Okay.
This is from Ammar. He's asking about the association between migraine and PFO. So if the patient is having migraine, this would increase the indication for PFO closure?
Not in my opinion. It's a great question. It's a super interesting question. I mean, we know there's an association between migraine with aura and stroke risk. People with migraine seem to have a higher risk of stroke. We know there's an association with the PFO and stroke, and then PFO and migraine, there's also clearly seems to be an association, particularly migraine with the aura. So it could be contributing. We think it's contributing to that, but there's been 2 randomized trials so far of PFO closure specifically to treat migraine, both of which were negative for their primary endpoint. There's some suggestion that it might help, and I certainly don't. I wouldn't conclude that it doesn't help anybody for their migraines, but we need to figure that out more before we're recommending it, particularly if they've not had a stroke. I think, closure for migraine is a terrible idea at this point outside of a trial, but it also doesn't really play into my decision-making for closure for stroke prevention. Either they need it for the stroke or not, and the migraine's sort of not something I take into consideration.
I hope I understood the question right from Aaron. He is asking about this 60 years old patient with embolic stroke and positive BFO, so without associated risk, and the patient doesn't want to do intervention. Would you recommend aspirin or NOACs?
Again, I think it's a really important question. We don't have definitive data on this. You could, if a patient wanted to be very aggressive and was willing to pay for and take the NOAC, there's a suggestion that maybe it's a little bit better, but the randomized data doesn't strongly support that. The data suggests that NOACs are perhaps as good as closure, or excuse me, anticoagulation is as good as closure, but when you compare it to aspirin, we don't have the conclusive evidence that it's better than aspirin. So I think it's uncertain. And again, if a patient doesn't want the closure, does want to be aggressive, you could talk about taking a NOAC, but in general, in my practice, my first line would be to recommend aspirin.
From Suleiman, also again for Dr. Stephen, he's having a patient 61 years old, dyslipidemic only, with TIA, with a small PFO, without atrial septal aneurysm or shunt. Would you consider closure?
So this is one of these people who aren't in the trial, and we have to kind of extrapolate the data. I think, you know, they're over 60. They had a TIA, which it depends on how compelling it was as a vascular event. If it was like tingling in an arm for an hour, I'd be less compelled than if it was a left MCA syndrome, you know, that passed in 15 minutes and didn't show infarct on the MRI. But based on the age, only a small PFO, no atrial septal aneurysm, no large shunt, it doesn't have those high risk PFO characteristics, and there was no infarct, I would not recommend closure in that population, in that patient. That would be my recommendation.
From Obey, I guess Obey is asking about the hypertension, because the question is regarding the eclamptic patient. Is there a special protocol? Maybe this is for Adam.
I usually defer to the obstetricians. In the United States, the recommendations are to treat systolics over 160 in an eclamptic patient. Knowing that the risk of eclampsia is higher than the risk of lowering blood pressure acutely in stroke, which, you know, there's maybe a little bit of risk, but it's eclipsed by the risk of eclampsia, which is life-threatening. So I would let the obstetrician bring them down under 160, certainly, regardless of if they're in the first 24 hours, etc.
The next question from Mohammed Farhan. He's asking about, again for Dr. Stephen, asking about the primary prevention of PFO. I guess he means that if we discovered accidentally that the patient is having PFO, especially if it's, for example, fulfilling the Europe criteria, would you close?
Nope, not for primary prevention.
Okay.
It's so common. I think it's you're putting them at risk of a procedure and all that, and cost without any clear proven benefit.
Again, a question regarding the association between migraine and PFO, the hot topic, and relation also to AF. Any further data? Because of course the old trials it negated that we need to close the in migraineurs the PFO. So any new data regarding this respect?
So no, I mean, at this point, again, the data we have suggests you shouldn't close a PFO in order to treat somebody's migraines. They are looking at, there's a new randomized trial that I think is going to be selecting patients based on responsiveness to aspirin Plavix. If they think that if you're responding to that, maybe you're more likely to benefit from PFO closure. And so, that'll be very interesting. I look forward to seeing those results. But otherwise, again, migraine's not an indication for closure as far as I'm concerned. I don't know of any data suggesting that migraine is a risk factor in patients with PFO for stroke per se. It's just that there's all of these associations with one another that we know about between PFO and migraine, PFO and stroke and migraine. But not necessarily that if you have a PFO and you have migraines that you're even, 4 times the risk or anything like that.
This is from Suleiman. Would you consider closure of PFO without aneurysm or shunt in a patient with TIA, age less than 60, without risk factor?
So this is right. This is a younger patient than that other one that we talked about before. There's not the high risk PFO characteristics, which would be strikes against it. There's no stroke, and all the trials only enrolled stroke patients, no TIAs besides the closure trial, which was negative. So I think it would be depending on how compelling the TIA was, and I think you can have that discussion with the patient saying that we don't know that this is going to benefit you and there's real risk. And so I would try to steer them maybe away from closure, but you could have that discussion with them. That shared decision making is always very important for PFO and stroke clinical decisions.
Actually, the questions are popping up, and the organizer is hinting that we are already delayed. So maybe for the attendees, you can just put your question, and I hope our speakers can just answer their questions